are listening to part 95 of our series, 7 Medicines, The Wise Woman Way, with Susan Wade at Time Monk Radio. Hello, Susan, and welcome back to Time Monk Radio.
Thank you so much, Gemini. I'm really enjoying our time here looking into how we can help ourselves when we are choosing surgery and what we can do there. Last week we left off talking about the new idea that you don't really need to have nothing by mouth, NPO, nothing per aura, nothing by mouth, for hours and hours and hours before your surgery. In fact, so many people talk about, don't get dehydrated, and yet here we are sending somebody in to experience something that can cause such a strong stress response that it can kill them. And we're saying, and go dehydrated, go without fluids. No, not good. And neither is fasting. A number of prominent studies have been conducted in recent years showing that allowing patients to drink liquids up to 2 hours prior to surgery does not increase the risk of choking or other complications associated with receiving anesthesia. In fact, it reduces the risk of complications. Patients allowed to drink clear fluids have less anxiety, require less intravenous fluids during and after surgery, maintain a better metabolic rate when put under, and recover better after the procedure is complete because their blood sugar remains steadier. Well, duh, we could have told them that, huh? Many patients also report feeling better overall without the stress of fasting on a day that an already stressful event is taking place. All right, it's not just anything. Clear liquids is what's used. That's water, juice, sports drinks, coffee, tea, but not with milk. And, of course, nourishing herbal infusion. My absolute choice for a herb, for the beverage to drink before surgery. Nourishing herbal infusions, come free if you can deal with the taste of it, or nettle because it helps build strong blood, or even linden because it's so soothing. They have also found that eating before surgery is not so bad, and that if you feel that it would be better for your blood sugar, eat plain toast or crackers, nothing with fat, all right, so that it will move through your stomach kind of quickly. In fact, the vast majority of food, even fatty meat, is out of the stomach within 4 or 5 hours, and so should be clear before the surgery. The 8 hours is double what it should take for the stomach to clear, but we're now relaxing that as well and saying that maybe that for us, talk with your anesthesiologist, talk with your doctor, find out, what they think is the best thing to do. Okie dokie there. Modern surgical realities. A little more on NPO, nothing per aura, after midnight. The deaths of 2 women were due to these restrictions. But nowadays, endotracheal tubes are usually placed in surgical patients anytime complete anesthesia is used. And that ensures that the patients can breathe throughout the procedure, and they are designed to prevent choking in the event that debris goes through the tube and into the lungs. Does not please me. Approximately 30 studies have shown that patients who ingest clear liquids up to 2 hours before their surgeries have emptier stomachs than those who have fasted since the prior evening, challenging the entire notion of NPO. Again, what we're told is nothing by mouth after midnight, the night before the surgery, because if there's something in your stomach, you could throw up during the surgery, and that could go into your lungs, and then you would die from inhaling food. However, more than 30 studies have shown that this simply isn't true. In fact, what they found was that people would kind of stock up. They, oh, my God, I'm not going to be able to eat. And so they would eat large, heavy meals right before midnight to try to get some food in and then go to sleep. And that food would just sit there because digestion does not work while you're sleeping. And then they would wake up with all this food in their stomach. And just being able to have those clear liquids stops this kind of, overindulgence, overeating, this sense that it's going to be taken away from me and I have to get it. I have to make sure that I fill myself. And it's not a bad response. Again, remember, keeping that blood sugar level even is a very good idea. In addition, it's important to consider that today's medical environment is really different than what it was in the past. In the past, patients would spend the night in the hospital before surgery, and the surgery would start at the crack of dawn, making after midnight a really reasonable thing and enforceable. In other words, the patients were right there. It was pretty easy for them to not eat anything after midnight because there was nothing to eat, and they were awakened, 5, 6 o'clock in the morning and taken into surgery. However, today most surgeries are outpatient procedures, meaning the patient is at home the night before the surgery and returns home as soon as possible after the procedure is complete, either that day or the next day. Surgeries are also scheduled throughout the day all the way into the late afternoon. It's not reasonable to expect a person to eat nothing at midnight the prior evening if their surgery isn't scheduled until 3 o'clock in the afternoon of the following day. So you may be told don't eat anything early, don't eat anything after midnight, and you might want to challenge your doctor on that and say, how come? Is this something that is just, the standard, and it has been the standard for quite a long time? No one is to blame for going along with the standard. Are they aware of the current research that this is not the best option? All right, what do we have here? Monitoring. Patients under general anesthesia must undergo continuous physiological monitoring or they could die. In the United States, the American Society of Anesthesiologists, that's the ASA, has established monitoring guidelines which include electrocardiography and ECG, heart rate, blood pressure, inspired and expired gases, oxygen saturation of the blood, and body temperature. Those things are also monitored in the UK, and in addition, they monitor urine output, central venous pressure, pulmonary artery pressure, cardiac output, cerebral activity, and neuromuscular functioning. In addition, the operating room environment must be monitored for ambient temperature and humidity, as well as for accumulation of exhaled anesthetic agents, which could be detrimental to the health of the operating room personnel. And that just really made me sit back on my heels. I'm like, oh my goodness, there's enough anesthesia that the people are exhaling, that the people doing the surgery could be affected by it if they breathe. That one more reason for that surgical mess. It's not true of all anesthesias. It's not true all the time, but the room does need to be monitored for that. The immediate time after anesthesia is discontinued is called emergence. Emergence from general anesthesia or sedation requires the most careful monitoring because there is still risk of complications and death, but the pressure's off, shall we say, right? You're in the operating theater, you're in where the surgical team, and you're the anesthesiologist, and you're monitoring it. There's a lot of people there, and that's helping to focus in on what's going on with the patient, whereas when the surgical team goes away and just the patient there and everything is done, yet that time can be very, very critical. 7% of patients are going to have a collapsed airway in that emergence period and will die if there's not somebody there to intubate them. 3% of patients will have very low blood pressure and could faint upon getting up and knock themselves out or, again, kill themselves from falling. And about 3% of patients will have urinary retention enough to make them go, ow, ow, ow. If that's you, if you tend to retain anyhow, some parsley root tincture could be your ally there. Hypothermia, shivering, and confusion are quite common in the immediate post-operative period because the muscles didn't move during the procedure. And believe it or not, your muscles moving is what keeps you warm. That's why you shiver when you're cold. Your muscles get into gear and go rumble, 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 shiver, shiver, shiver. Let's get ourselves warm again. So it's not just that the operating theater is cold, and it often is kept quite cold, but it's also that you are laying there still, even stiller than if you were asleep. Post-operative cognitive dysfunction or post-anesthetic confusion is also called emergence delirium and early cognitive dysfunction. And it needs to be monitored and attended to. It's quite common in the emergent stage, but should taper off. And by the time the person is ready to leave the hospital, they should be pretty cognizant of what's going on. If there is confusion, cognitive dysfunction that continues on for a week or more, this is something that should be dealt with. Andrew Hudson, assistant professor in anesthesiology, tells us recovery from anesthesia is not simply the anesthetic wearing off. See, that's what I thought it was. And I would guess that's what most of us think it is. It's like, okay, I've been given these drugs and they have these different effects on me and they're not giving them to me now and they're going to wear off and then they just wear off and everything will be the same. No. The brain has to find its way back through a maze of possible activity states to those that end up with conscious experience. It's rather like entirely rebooting your computer. You know, I often have computer experts look at me and say, "You don't turn your computer off." And I go, "No, you're right. I just shut the lid on my laptop and it goes to sleep, but it doesn't really totally turn off." There's a little thing you have to push to get it to totally shut down and turn everything off. And of course, I'm a writer. I don't want all the things I'm writing. I've got, a bunch of things open. I don't want them all shut down because when I do totally shut my computer down, I have to tediously go in there and close all of those files, and then I have to go back and reopen them. It's a hassle. But anesthesia does that. It's a total shutdown. It's not just closing the lid and then you open the lid and it comes back. No. Everything has shut down, and your brain is going to have to do some major work to reboot itself. long-term post-operative cognitive dysfunction is the state that continues for months or years. That's why it is long-term. It is, however, subtle, and it is a deterioration. Usually the relatives of the person report that they have lost memory, they have lost attention, they have lost interest in activities previously important to them. Or people at work may report an inability to do their tasks as fast as they used to be able to do them. I remember when I first heard about post-operative cognitive dysfunction, and it really kind of took me aback because anesthesia had been explained to me as just putting people to sleep, and I'm sure you've heard that too. Anesthesia puts you to sleep. And so we think that, again, it's like closing the laptop lid. You just put it to sleep. You go to sleep, and then you wake up, anesthesia wears off, and you're there. But major changes have occurred in your brain, in your nervous system, in your heart, and in your lungs while you have been under the influence of these drugs. And there are a great many different anesthesias. So it's not as simple as that. There is pretty good evidence that there is post-traumatic shock after surgery and post-operative cognitive dysfunction after almost all cardiac surgery. It does occur after non-cardiac surgery, but it is deeply linked to cardiac surgery. Some anesthesias. Alcohol is an anesthesia. People drink to drown their pain. Anesthesias help us get rid of pain. So alcohol was the anesthesia of choice for most of the human history of surgery because we had it, because it was there, and because it does indeed numb the pain. And then, of course, there are the opiates, the things derived from poppy. And poppies have been around with us for a very, very long time. Opium, morphine, and heroin are basically plant-derived compounds, and they are called opiates. They are sleep-inducing, and, of course, there is the California poppy, which is a papaver, it is a poppy, but has a much milder effect than the opium poppy. Juliette Berkeley-Levy, who I mentioned last week, was very fond of dropping one or two poppy seed pods from her garden into some boiling water and then feeding that by the spoonful to teething infants to get them to go to sleep. California poppy is probably much safer. As we mentioned before, opiates are addictive. Opioids are drugs that are created based on opiates, and they include things such as methadone, phenantil, and OxyContin. These are much more dangerous than the opiates. Opiates can indeed create addiction, and they can kill. You can have an opiate overdose. We've heard of people having a heroin overdose and dying. It certainly can happen. But the opioids absolutely addict without any exceptions and are lethal even if taken in the proper dose. It seems like almost every day now when I look in the inner pages of the newspaper that there's a little article tucked away about a toddler, occasionally even a crawling infant who finds mom's or dad's phenantil or OxyContin and doesn't even take it, handles them, touches them to their mouth, touches their hand to their mouth, and dies. These are dangerous drugs. We talked when we were talking a couple of weeks ago about things to do to relieve pain after surgery, about the endocannabinoid system. And we talked about using high CBD tincture. Cannabis, of course, is an anesthesia, but so is its a dear friend hops. And you know what? Even chocolate can be a mild anesthetic. I don't think we're ever going to get to the point where we say, okay, I need you to eat 2 bars of chocolate before I do this operation on you. But it's good to know that chocolate does relieve pain. Cocaine is an anesthesia, and it, of course, comes from cocoa leaf. And we get benzocaine, lidocaine, procaine, and novocaine from the cocoa leaf. Betel nuts also have some of these effects. Also, filipendula and Achillea millefolium. Filipendula being one of the meadowsweets and Achillea millefolium being yarrow. Also have cocaine-like properties locally. A couple of weeks ago, I taught a class on digging roots here at the Wise Woman Center, and because my ground is very rocky, I went elsewhere the day before and dug a few roots and kept them in water overnight so we'd have some interesting roots that don't grow here to play with, and one of those was the root of evening primrose. And I had read that it was used as a foodstuff, so I rather casually passed it out and with a knife and allowed people to cut off a piece and to eat it. And a couple of minutes later, people are saying, did you know that this is an analgesic? I'm going, what? Because, of course, I didn't eat a piece. I was teaching. And they said, our mouth is numb. Our tongue is numb. This is some pretty amazing stuff. So there is yet another one to add to this list. And whether it actually has cocaine-like constituents or not, it certainly has cocaine-like effects. Ether is a great anesthesia, and ether was kind of where we put our toe into the modern world of anesthesia. Unfortunately, ether is really flammable. And surgical suites, operating rooms, and the patients therein were going up in flames when ether was the primary thing used. And so we kind of switched over to chloroform. And chloroform figures rather prominently in some Nancy Drew books that I've been reading to my granddaughter, where the bad person has a wet rag which they rip out from a bag and press over someone's face. Chloroform has some very big drawbacks. And so we kind of left chloroform behind and looked for other things, and nitrous oxide was one of the next things that we found. Nitrous oxide is sometimes called laughing gas, and dentists very much picked up on the use of nitrous oxide and offered that to their patients. Ketamine is a psychoactive drug. It gives you quite incredible visions, and it's an anesthetic. And it has gained some popularity both as a psychoactive short-term, very short-term psychoactive, and as an anesthesia. And then, of course, we come to the great long list, which I won't read for you, of both inhaled and injected anesthesias, which, as we said, can work to do a wide variety of things. The American College of Anesthesiologists suggests that you check in with them if you have any questions at all about who your anesthesiologist should be, that you should make sure that your anesthesiologist is indeed certified by that governing body. And several people have said to me that they believe that the skill of the anesthesiologist is more important to the long-term consequences of the surgery than the skill of the surgeon. I don't know if I would go that far, but again, as I said at the beginning of our talk about anesthesia, the anesthesiologist is truly the one who is holding your life in their hands. If you are going to have surgery, the surgeon will be fairly casual about it. After all, that's what the surgeon does day in and day out, is surgery. And yet one surgeon said to me in a moment of candor, one thing that we don't tell people is that once you have surgery, the likelihood for having another surgery goes up very, very high. And I looked at this MD and I said, is there a particular reason for that? And with a blush and a sheepish grin, I was told, yes, because surgery often has the consequence of messing something up, which we later have to go back in and change. We're in the seventh river of healing. This is not a safe place to be. Surgery is an absolute miracle. Anesthesia is amazing. We can repair hair lips and cleft palates. We no longer see children with club feet. We are able to restore looks and health to a great many people who in prior centuries simply would not have had that possibility. But that does not mean that in our joy of seeing these problems dealt with, that we should forget that if we ourselves are getting involved here, that there can be more than meets the eye to saying yes to surgery. Is this something that we really need? The person who worked the closest with me in getting my books to press, a wonderful woman by the name of Peggy, who pasted up and helped me put everything together, had a brain aneurysm, and they suggested that she treat it with radiation, which would basically destroy the blood vessel before it could rupture. And she was very much afraid of that radiation, so she asked for a different procedure, which was a balloon procedure, and they threaded a balloon at the end of a very, very long probe all the way up through her blood vessels and right up to that area of the brain. And the idea was to get the balloon into that blood vessel and then to blow the balloon up so that it would block the blood vessel and keep the blood vessel from rupturing. Unfortunately, what happened was that the balloon blew up the aneurysm, and my friend died. We're in the seventh river. It's a very dangerous place to be. And the danger is not just surgical complications. It's not just equipment failure. It's not just the problems with anesthesia. There are also the problems of antibiotic-resistant infections and the problems of post-traumatic shock after the surgery. I'll be back next week to talk about these things with you. Thank you, Gemini, as always, for giving me this time and this space to share green blessings and to help us all remember that even when we are feeling like everything is totally out of our hands, that we still have some power. Good night and green blessings.
Thank you, Susan. And this concludes part 95 of our series, The 7 Medicines the Wise Woman Way, with Susan Wade at Time Monk Radio.